I'd like to, I'm sorry, I apologize, I'm cutting into our question time for a little bit, but if you just permit me, because we got started a little bit late, just a little time, and I'm looking at the bosses in the audience, if that's okay, if I can take a little more time, to talk about how do we optimize outcomes in FAS, how do we promote resilience. And this is where I'd like to leave us on, kind of on an upbeat, hopeful note, to recognize that, brain development starts in utero, but continues throughout the lifespan. So when you pop out of the womb, your brain is not done developing. So this idea of the neuroanatomical organization continues, that there are these areas that are, consolidating in utero, but there are parts of the brain like myelination, the organization of the prefrontal cortex that continue early in childhood. So these capacities for self-regulation and executive functioning development, those neural systems are continuing to evolve really, into adolescence. And so we have to recognize that even though the damage was done in utero, there is the potential to, there's potential for remediation. And there's potential to reorganize parts of the developing brain that were damaged in utero. Can we ever get to the state as if there was no damage? Can we ever completely undo the damage that's already been done? I don't think so. I don't know that we have an answer to that definitively, but what I can say is we can certainly put interventions in place that can affect a child's developmental trajectory and help them reach their developmental potential, whatever that potential is. And so when we think about how do we optimize outcomes in children with fetal alcohol spectrum disorders, how do we promote resilience, I would say that there's a three-legged stool or a three-pronged approach that I think we need to consider. And this really talks to a systems approach. We need to think about diagnosis, so early diagnosis makes a difference. We need to think about intervention, that when we identify that these children are at risk, even if they don't meet diagnostic criteria, can we provide intervention that addresses their vulnerabilities in hopes of optimizing that developmental trajectory? And I think we need to think about prevention. So we know that this is a very preventable disorder. It is the most common cause of preventable mental retardation. And it only happens one way. That is if a mother drinks during pregnancy. And so thinking in a really compassionate way about women who are drinking and working with women who are drinking in pregnancy, can we do two things? Can we say, if you are drinking in your pregnancy, can we help you to stop so that whatever damage has been done to the developing fetus, that we stop the damage right there. And we know that women who stop drinking in pregnancy have children who have better outcomes than women who continue drinking in pregnancy. So if they're drinking, can we do prevention? Can we stop the drinking? And then can we educate such that we don't perpetuate the cycle in the next pregnancy? And so we say, okay, there was drinking in this pregnancy, but you know what? We have a chance to do things differently with your subsequent pregnancy. And so can we take a really gentle, broad-minded, and compassionate approach with these women and say that, throughout the lifespan, there's always an opportunity for behavioral change, and be open to and be supportive of women and help them in that process. And so thinking first about this idea of diagnosis, that we know, and this comes from the CDC, that the FAS diagnosis and the diagnostic process is really part of a continuum of care. And really our goal should be to identify and facilitate appropriate healthcare, education, and community services. So that diagnosis is just a part of the whole treatment plan. And that we know that children who are identified prior to age 6 can get services that really help them reach their developmental potential. And we also know that the brain is organizing and continuing to develop early in life. And so if we can make that diagnosis prior to age 6, these kids will have better outcomes. Of course, the challenge to making the diagnosis prior to age 6 is that those developmental deficits may not be present at the threshold that they need to qualify for sort of CNS impairment. And so when we think about how do we promote early diagnosis and how do we think really strategically about identifying children with this condition, it's recommended that we target high-risk populations. So a lot of you here work with high-risk populations, children in the foster care system. So kids in the foster care system are 10 times more likely to have an alcohol-related diagnosis than children not in the foster care system. Can we use the child as the point of entry? So children with substance abusing mothers, if there is a history of substance abuse, very often there's a history of polysubstance abuse, where alcohol is part of that polysubstance. Children in foster care, children who have been internationally adopted, I think because of a lot of the recent legislation, that door to international adoption is closing. But so we're seeing less kids who are internationally adopted, but it is something for us to sort of keep on our radar. When we think about promoting prevention, we know that what we want to do is be sure that the mother has information to prevent FAS in future births. So this is a different approach. Rather than using the child as the point of entry and the point of intervention, we're using the mother as the point of intervention. And I have to say, it's really important to develop a therapeutic alliance with those mothers and to be really compassionate and not judgmental, to really take the framework that a woman who drinks in pregnancy is not doing it out of a spirit of malfeasance. She's not drinking with an intention to harm her fetus. Very often, women who are drinking, who are substance abusing, have their own vulnerabilities in terms of their own perhaps mental health needs that have not been met, and so they're self-medicating with drugs and alcohol. They perhaps, there's a much higher incidence of these women experiencing domestic violence and intimate partner violence, and living in poverty and having lives that are really, really chaotic and difficult. And so their use of alcohol in pregnancy may be, as we suggested, an act of self-medication to try to anesthetize themselves from the pain in which they're experiencing. And so if we can take sort of that Delta Airlines approach and that view that some of the reasons, the behavior in which she's engaging may be at some level somewhat out of her control, to be able to have that sense of compassion for her. So
she could be alcohol affected herself.
And she could also, that's absolutely correct, that we know that there is this intergenerational pattern of behavior, and a mother who is drinking during her pregnancy may herself be on the spectrum and not have been diagnosed, because this is a diagnosis that is only 40 years old. So you know, women may not have that have had the benefit of a diagnosis. And so we talked about children who are born to women who stop drinking in pregnancy have better outcomes than women who continue to drink during pregnancy. And so then this idea of promoting intervention, some of the protective factors. And so these are the things that we can really hold on to, that we know, and this is not just children who have been alcohol exposed, but these are all children in the foster care system, children who have been maltreated. We know that early child development and optimal child development requires a stable and nurturing caregiving environment during the early years. That we know that children do better. This is not just kids with alcohol, these are all kids. Children do better when they are not exposed to violence. Children do better for kids in the foster care system when they have a minimal number of placement and caregiver changes, when they have an opportunity to develop a secure attachment to a caregiver, when a permanency plan is put in place. And so I'm grateful that we have people here in the audience who are judges, who are working in the legal system, to think really thoughtfully about permanency planning, about how do we make a stable caregiving environment for a child with a caregiver who can really understand this child's needs. And can we get them connected to social and educational services? And so I'm going to highlight this last piece, eligibility for social and educational services, because as we know, these kids who are prenatally alcohol exposed have multiple different areas of need. And so just looking at this constellation of developmental and behavioral vulnerabilities, there are lots of points of entry for services through the school system. When we think about our infants and toddlers, again, lots of areas of developmental behavioral vulnerability which can which can make them eligible for special services. And so when we think about these infant-toddler symptoms, these are multiple areas of, these are multiple domains for which they can qualify for services, including infant mental health services to address the attention concerns, physical therapy to address gross motor concerns, occupational therapy to address fine motor, visual spatial integration concerns, so, speech therapy to address language deficits, early childhood intervention to address some of these cognitive impairments, and then infant mental health to address some of these deficits in self-regulation. So if we are identifying delays, if we are identifying vulnerabilities, we really have a responsibility to connect these kids to services, even if they may not meet the strict diagnostic criteria. And so then I want to spend a little bit of time talking about these protective factors, about how do we promote stable caregiving environments for these children. And so this is a picture of that one of our little ones had drawn. I think he was 6, and he talked about his experience of caregiving. And he had, for those of you who work in the child protection services, this was up on the left of our screen, this little angel, and this was his, what he called his angel mommy. And this creature with like the angry jaws and very angry face was basically his depiction of his mother. And so this was a child who had experienced pretty chronic maltreatment. But then he had this angel mommy who came in, and basically what happened is, you know, that the mean mommy, you know, was in his mind incarcerated or put away, or basically he was put in someplace safe. And then this angel mommy became his super mommy. And so this is how he conceptualized his foster care worker as his little guardian angel, as the person who was there to keep him safe in the foster care system. And so basically, when we think about what young children need, I love this cartoon from the Family Circus. He says, "This is my favorite place inside your hug." This sense that a child has this internalized experience of safety, security, and stability in the caregiving environment is really, really important. And so I'm just going to present a couple little ways of sort of tools for the toolbox. As we're thinking about a systems approach and addressing the needs for these children, I think one of the most important things that we need to think about systematically is diagnosis. So how do we propose diagnosing and identifying these kids who are on the FASD spectrum? And so I think it's really important, and this can happen from any of us, this doesn't have to be a medical provider, but how do we ascertain that there's been a history of alcohol exposure prenatally? And then we need to be able to partner with agencies, with medical establishments to provide a comprehensive diagnostic evaluation. So these kids need to have a really thorough physical exam with someone who is really skilled in dysmorphology, who can look at their facial features, their growth, and see whether this pattern of physical features could be accounted for by another diagnosis. And then we need to have someone who's really developmentally skilled and who has a special expertise in the developmental, behavioral, and neurocognitive profile of kids who have been alcohol exposed, to see whether they have that CNS pattern of deficits that can be consistent with prenatal alcohol exposure. And then we need to be able to provide developmental and behavioral services to address these areas of vulnerability, whether that diagnosis is met. There are manualized programs that are out there. One is promoting first relationships for parents of young children, and then the Circle of Security program. There is and maybe some of your agencies are already getting trained in Circle of Security, which is a really lovely, there's a brief 8-week parenting intervention program, and then a more intensive 16-week therapy program that really is attachment focused, that focuses on teaching the parent to be a secure base and safe haven for the child, to teach the parent how to watch over their child, delight in them, help them, support them, and when that child is dysregulated, to provide an environment where that child can come back to the family. When that child is dysregulated, that child, especially in these kids who are on the FAS spectrum, there's a need for a parent to be able to be a sense of consistency for a child, and a sense of stability when internally that child is perhaps feeling very unstable. So the parent needs to be able to be calm and take charge, be kind, and be sort of this regulating presence for this child when the child's feeling very dysregulated. And then to provide a sense of options in terms of how strategies to help that child self-regulate. And then that child needs to have a sense that, especially if these are kids who have had a history of caregiving insensitivity, if they've been in a history of foster care or have had a history of maltreatment, they need to know that there is an environment and a caregiving system that can be stable, because for a lot of these kids, their experience of trust and caregiving has been really horribly violated, and so they need to have that experience again. And then finally, if this is a parent who has had a history of substance abuse, who has had a history of alcoholism, who herself is going through substance abuse treatment, she needs to have, needs to have a paradigm shift where her child becomes more important than the drugs that she's using. Her child needs to be, for her, needs to be that motivation. So for a substance abusing parent, the drug is a motivator. You know, it affects the limbic system, and the drug provides, you know, a biochemical high. What a parent needs to experience is the child being that motivator for her. And so it really is a circle of change, a paradigmatic shift, where the parent learns to put the child first, that the child's needs come before sort of her own needs. And so thinking about this, as we're thinking about resilience and how, and in our working with our families, what we want to do is help parents simplify the environment. We want them to be able to respond and not react, and then to be able to go forth and provide consistent and nurturing care. And I think one of the most lovely examples I've heard is from the Circle of Security Project, and they talk about what every parent needs to do. And they need to always be bigger, stronger, wiser, kind, whenever possible, follow their child's need, and whenever necessary, take charge. So on that note, I know that what all of us are trying to do is to provide for children this internalized experience where the child can say, this is my favorite place inside your hug. And so on that note, I just want to say thank you.